morning. I'm Andrew Demers, the Communications Director here at the New Hampshire Insurance Department. Happy to welcome everyone to this month's webinar as we discuss GLP-1's, their costs and alternatives, a few things that regulators and consumers need to know. A couple of housekeeping items. We're happy to entertain questions. Please enter your questions into the chat window, and we will address those at the end of the presentation. Before I turn it over to Commissioner Betancourt, I just want to say, it's one thing when you have a colleague as knowledgeable as Dr. Az is. It's another when knowledge marries passion. And so you're going to see that in today's presentation. We're all very excited for this. I'm happy to introduce our Commissioner, DJ Betancourt.
Well, thank you, Andrew, and good morning, everyone. And thank you for joining us for this month's webinar. As Andrew mentioned, today we are focusing on GLP-1 medications, a topic that has generated a lot of attention. And with that attention has come a lot of questions, particularly around their use, their coverage, and their cost. Our goal, as it is for all of our webinars, is simple: to provide clear, consumer-friendly information so that individuals and families can better understand what these drugs are, how they work, and the issues that may arise when it comes to insurance coverage. We like to keep things high level, focused on education, and leave time for your questions at the end. So with that, let's get started, and I will get it started by introducing our subject matter expert for today. As Andrew mentioned, that will be Dr. Jason Azes. Dr. Azes is an exercise physiologist and nutrition scientist who now works as a health economist here at the department. He is a professor of physical activity, nutrition, and health at Tufts Friedman School of Nutrition, Science, and Policy. Throughout his career, he has witnessed the insidious effects of obesity, but also sedentary behavior and poor diet. Taken together, he aims to share a holistic perspective of this complex issue, most specifically, of course, for today's webinar, obesity in our population, and factors that may help align and enlighten policymakers on effective solutions to this pressing social, clinical, and public health issue. So Dr. Azes, hopefully I got that intro right with all of those sciencey words. I may have stumbled a time or two, but hopefully everybody gets the picture. So Dr. Azes, I'll turn it over to you.
So the commissioner talked about this. I mean, you cannot watch a television program without seeing an ad for these weight loss drugs, and you hear about it in news stories. There's probably a really good reason why, and I think it has a lot to do with what we know throughout our lives about overweightedness and obesity in our society. It's indeed a pervasive health condition that has lots of complexities, lots of underlying causes, none of which are the same for each individual nor each segment of our population. And so it became difficult to put together and synthesize a set of concepts for this presentation, knowing that reality, how much it varies, but also in looking at our audience list, the attendees from different segments of our population, people from the pharmaceutical industry, from healthcare, and just the layperson, citizens who either know someone or they themselves suffer from the dumb anguish of overweightedness and obesity, and regulators in the field. So I hope I can achieve that condition of giving broad, 10,000-foot holistic information, but something that's useful, maybe something that you didn't already know. So I welcome your feedback on that front. So I just listed some of the learning objectives because this is useful more for me than for you, so I can try to meet that condition that I just mentioned. But I hope you know more about these concepts that I won't mention. I'll allow you to peruse by the end of this 20-minute short, brief presentation. And at the end, you can see that term obesity paradox, and I'm uncertain to what extent anyone in attendance has heard about that term, but I've long thought about this term, and you'll hear a little bit more about that. And I think when you leave this presentation, maybe when you're driving home, you'll have something to think about with, that may reform how you think about obesity as a driver of disease and other social permutations that this condition, that's only getting more pervasive in the U.S., exerts upon our great population. So, one of the things we do here at the insurance department, I think it's noteworthy, the way I look at health insurance is that the health insurance system in the US finances the delivery of healthcare services. So the way we often frame obesity in its costs is oftentimes economic costs. But it's noteworthy that the cost transcends beyond dollars and cents. There's social costs and clinical costs and other types of emotional costs that are exerted by obesity. And there's a lot of health economists that have aimed to try to quantify them or measure them. And it's noteworthy that costs can be either direct or indirect. Example of a direct cost are for GLP-1's or bariatric surgery or knee arthritis that's caused by, enduring the mechanical stresses of overweightedness for many years. Indirect costs could be something like absenteeism at the workplace or some long-term health conditions that are made worse by obesity, like diabetes-related conditions and kidney disease. So taken together, it is a massive cost exerted to the total healthcare system that ranges somewhere between 150 to $200 billion a year. And it's increasing more and more every year that goes by. But that's a hyperbolic figure that it's hard for an individual to contextualize. So I like to put it down to the per capita level. And it's noteworthy that obese individuals spend over $1,800 a year in their healthcare costs compared to non-obese individuals. So that really hits home if you have that scarlet letter on your shirt, meaning if you do meet the diagnostic criteria for obesity, then you on average pay $1,800 a year more. And that value goes up across a continuum of obesity classes. There's not just one type of obesity. There's stage 1 and then stage 2 and stage 3, which sometimes we call morbid or so severe obesity. That cost increases. So obesity is considered a chronic disease. I think most of us here know about that, right? But it's important to understand how obesity is defined. And surprisingly, there's not necessarily in the whole world a consensual definition for obesity. I'll share with you a couple of them. And first here is the World Health Organization. Interestingly defines obesity as an abnormal or excessive fat accumulation. And then they go on to reference the BMI or the body mass index. And then the CDC refrains from referring to the term fat or adiposity, which adiposity means fatness on the body. And importantly, I think fat cells on the body are called adipocytes or adipocytes, right? So adiposity refers to this kind of overarching idea of having fat on the human body. And whereas the human body, by necessity and for survival, needs to have fat, excess accumulation of fat on the body is essentially the construct for defining overweightness and obesity. But the point about the World Health Organization's definition is that we use BMI as a measure to classify obesity, but BMI doesn't consider adiposity at all. It's really just the ratio of height and weight that we use to define it. So there's a little disjointedness in some of the definition, but I'll tell you more about that in a moment. So first I want to share some alarming, stunning statistics that won't surprise you really, right? And so the US, also known in my lens as the best country to live in the world, is a leader in many, many areas. Most of them are good, but we also lead the world in obesity prevalence. And in case you haven't figured it out by now, I don't think that that's really good. And so the several different definitions, two of which I just mentioned, are really defined right here. And you can see the green zone is really where you want to be. And most Americans are either in the bottom yellow zone or the red zone, which communicates really the three key classes of obesity. There's this concept of abdominal obesity. I just really essentially called into question the World Health Organization's definition of obesity, where they refer to fat accumulation, but they refrain from the measurement of it to classify people. if you give that enough thought, you'll think that there's something not right about that. This measure of abdominal obesity really is not rather new, but relates to measures of waist circumference, whether it's a direct measure of waist circumference, which I'll communicate in a minute, or it's a ratio of the waist circumference and the hip circumference. We've heard of that in maybe the terms of waist to hip ratio. So these are the variables in the diagnostic cut points for abdominal adiposity using just waist circumference or the waist to hip ratio. What that does, that it's noteworthy that there's a much higher correlation between waist circumference and adiposity versus BMI and adiposity. And I do want to point out that there is a correlation to BMI and adiposity, meaning how much fat, but it's not a direct measure of that. And for some segments of our population, I happen to exist in one of those segments. BMI is a poor predictor of adiposity or has a low correlation coefficient with adiposity. So for those people, BMI overpredicts obesity, if you will. And that's something that, if we're using BMI as a clinical guidance tool, there may be improvements that we could make. And I hope that that's one theme from this presentation that may be a take-home message for you. So, here is the stunning statistic. The most recent prevalence data from the NHANES, the National Health and Nutrition Examination Survey, the CDC data set, that's very authoritative. 40.3% of Americans meet the BMI condition for obesity. And that's alarming. And that's, as a note, higher than the last NHANES cycle and higher than each preceding NHANES cycle. In some, it's only getting more and more prevalent. In terms of abdominal adiposity, those measures I just mentioned, that actually even has a higher prevalence, which you can see here. So meaning Americans have a lot of issue with waist circumference and fat around the middle of the body. I'm not going to get into some of the underpinnings on why the human body stores or increases its adiposity right in the middle of the body, noteworthy where the pancreas is compared to other parts of the body like the appendages. But that's one of the key reasons why, I'm very interested in waist measures versus whole body measures to assess what are some of the cardiometabolic risks of storing excess fat in the middle of your body. So now to the topic at hand, right? So GLP-1s and GIPs, they're both really very similar, even though the pharmacokinetics may seem different. And the names, the strange, unusual, cute names that you'll see on these television ads are quite different from each other, right? So I'm going to just go through these bullets and not mention too much about it. And our communications team is going to share these slides with everybody in the audience that wants to dig a little bit deeper. But I just wanted to kind of answer that question, what are these drugs? And then the next question, how do they work? And then we can maybe get into a more narrative approach to talking about these complex topics. But, big word alert, right? And I know that I think the commissioner gives me like 3 big word cards for each of these. I can use 3 big words. Well, here's my first one, endogenously produced. That means you make this protein in your body, inside the body. You make this. And that's a great thing, as I live my life as a type 1 diabetic, and I don't make insulin, and I actually make a lot less of this protein too. So my endogenous production is very, very much less with regards to GLP-1 and insulin compared to my non-diabetic counterparts. But this is produced inside the small intestine and some of it in the pancreas. It's produced in response to a food bolus or when you eat. And it's really fascinating I used to think the brain and then the heart, those were the most intelligent organs in the body. And after I finished my doctoral work at Tufts, I really thought that in that mix is also the gastroenteral tract. The human gastroenteral tract is very intelligent. This is an example. When you eat foods, carbohydrates, fats, and proteins, we call those macronutrients. Your digestive tract can detect how much of it, but also what which macronutrients it's being exposed to, and then it will secrete a variable amount of these GLP proteins into the bloodstream. And those proteins have these acute effects. They stimulate insulin secretion. They inhibit gastric emptying. That means how quickly food moves through your digestive tract out of your system. And think about, managing hunger and satiety. If food can stay in your digestive tract for longer, it can, give you a sense of fullness, or we call that satiety, for longer. And that's really a really important behavioral target if you think about it. And the net effect is it promotes satiety. And importantly, I want you to leave with this kind of a concept in your mind, is that these are all components of that, that very intelligent system we call the gut-brain-pancreas axis. More broadly, some people refer to that as the neuroendocrine axis. How, your endocrine system and your nervous system are given information from yet another organ system, the gastroenteral tract, to tell you about how hungry you are or whether you've been satisfied. I'm always envious as I learn more and more about that part of human physiology and metabolic physiology, because it really is very dysfunctional in type 1 diabetics and other people who suffer mightily from metabolic diseases. So the next thing I kind of want to bring up with regards to that is another big word. So here's my second big word card: exogenous form of these medications. They're known as incretin mimetics. Exogenous, if you can kind of contextualize it, that big word, it means from outside the body. So if we make this protein inside our body, but it's not doing enough for us, we can take an isomerized or synthesized form of it in an injection, and now we have more of it. And these are called incretin mimetics. And indeed, these medications actually meet that condition. They're defined as those, right? And so I just want to tell you what the incretin effect is, because it's so brilliant, and I'm so envious that I really it's very much blunted in my day-to-day life. It's this phenomenon for which an oral glucose load elicits a much higher insulin response compared to an intravenous glucose load. Now, that might not mean much to you, right? But what this does is, if you think about that over time, and it does take much thinking, if you think about that, that's the whole reason why we're here right now today. That's what this whole therapy aims to do, right? Because if you could just have a glucose load in the bloodstream and your entire endocrine system would respond, that would mean that there's not this relationship between what happens in your gut and how it tells your brain that you're full. But that's not the case. We do know that there's a very fervent incretin effect, and that's really the targeted pathway for these medications. I think that's kind of cool, and I hope that's an innovative idea and message for most of you. I do know that we have, and we're blessed to have some members of our audience from the pharmaceutical industry, and I think they're probably well aware of that. And so they, deserve credit for helping to develop these lines of therapy that can help a lot of people. But I wanted you to walk away with that message. So a little bit more on the mechanism of action, right? So the central nervous system, so the brain essentially, right, in this case, has receptors for the GLP-1 and GIP proteins, both in the brain and in the peripheral tissues. It's important to note that there is a difference in the concentration of receptors in the brain versus peripheral tissues, compared to comparing the endogenous to the exogenous GLP-1, meaning when you take the injection, there's a much greater receptivity in the brain compared to like the skeletal muscle tissues. The endogenous GLP-1, the one you make, has lots of target-specific receptors in the muscle tissue. I know that seems weird, but recall that I'm an exercise physiologist who became a nutrition scientist. That's a very, very important distinction. More on that maybe later. So this other information is just deeper information on the mechanism of action. And I just wanted to reiterate, right, what's the net effect? The net effect is that this protein, whether it's endogenous and especially the exogenous form, it mimics the sensation of satiety in the hypothalamus of the brain. It tells us that we're satiated, that we're satisfied with food, when we may or may not necessarily be. And that's it may not be surprising that that's a therapeutic target in the United States, where we tend to overconsume food, or maybe more intelligently stated, we tend to eat a quantity of food and energy that exceeds our body's expenditure requirements. We eat more than we need to. And that explains about 85 to 90% of weight gain in our population. The fact that we don't match our energy expenditure to our energy intake. Oh, imagine if you did that with your automobile, right? It'd almost be hard to imagine that, because we have lots of really direct measures and we have very little emotional attachment to fueling a car at the gas station. Ask yourself, can that same condition be said about the way that we fuel our bodies? And keep that in your mind as you drive off after today's presentation. So, one question I wanted to ask, and there are no well-equivocated answers to this question, but I'm remiss to not ask it, right? Is that target in the brain, in the hypothalamus, right? Affecting the reward centers of satiety, is it limited to just food satiety? We're hearing signals now that that these therapies might be useful for addiction and substance use disorders, right? Because they're like, those are right implicated right in the reward centers of our brain, in the hypothalamus, right? But what about other types of reward center stimuli, like things that are good? Not all rewards are bad, right? What like recreation, intimacy, stimulating your brain in other areas like arts and things like that. One signal that we're hearing from clinical communities and some of the recent clinical trials is that, in case study reports too, is that it's really not target selective, meaning that there are a lot of other reward centers that are affected by these therapies. Whereas I really, as a scientist, I really like to stick to what, where there's observational data that can confirm that. I did want to bring that up, and kind of maybe later we'll talk about just two proxy measures that might tell you a little more about that. So, to sum all of that up, what are they and how do they work? I just wanted to just point out this important thing, right? That there's a good reason for Americans, I think, and everybody else in the world, for why this is an emerging and increasingly interesting topic. I mean, we hear these drugs referred to as miracle drugs, and whereas I'm warming up to that idea, and I do still have some dampened enthusiasm, it's important to recognize that there's a very steep trajectory to the popularity of these medications. And it was like in 2022, I think, that the net revenues for these GLP-1s exceeded $22 billion a year. So, and it's also noteworthy that I think the drug exenatide was one of the first that was approved by the FDA. So they've been approved for over 20 years. So they're not new. And what we also have noticed that there's a rapid market entry in a new competition for branded GLP-1 formulations, and now even non-injectable oral GLP-1s are really being investigated, right? So what as a health economist, you say, well, competition's good, right? Because it drives prices down. When firms compete for a market, they compete by and large maybe on price. We're not necessarily seeing that, and we're actually seeing the preservation of brand exclusivity be a price driver in the New Hampshire GLP-1 market. And it's also important to hear this, right? So we work with the claims data, and we just recently got the second quarter. So we've got half the year of 2025 pharmacy claims data, and we've looked at that. We're seeing already, just in most markets, more than $380 million of net expenditures for GLP-1s in the New Hampshire market. And that's an astonishingly high amount of absolute dollars, given the small state of New Hampshire and given the fact that it's one therapeutic class of drug. albeit an important one that treats a really important and expensive condition. And to help you contextualize it, that puts us on pace to reach a target of about $1 billion for this year in New Hampshire in net expenditures for that one therapeutic class. And that's a lot of money. You'll hear more from us in our fall annual hearing this October 24th about those net expenditures and what they will mean for the total cost of care in the state of New Hampshire. And I'll tell you this, in case you haven't noticed, it will mean a lot. That's a lot of money. In 2022, our state overall and all healthcare expenditures spent just a little over 13 billion. So 1 billion on just those drugs alone will be very, very noticeable in your premiums in future years. So the last thing I want to close on these drugs, right, are, how they work. And this is more in the behavioral economics construct, right? They help you eat less. And if they don't make you eat less, then they don't really elicit the weight loss that's the target effect, right? So I love a good forest plot. And right here is like a good forest plot from one of these studies that really looked at dietary energy intakes on patients using GLP-1s versus not on GLP-1s. It's a form of a randomized control trial. And you can see here on the right side of that isoquant, that middle line, which is hard to see, but you can see that all of the responses, the positive responses for patients not on GLP-1s are to the right. But you can see that there were, I think, 5 or 6 data points there. Most of them were not even significant, meaning most of them we can't really accept didn't respond that way due to just chance. So these were all monotonic favorable responses about people on GLP-1s that actually felt like they were less hungry. That's really powerful information, albeit rather hard to assimilate. So I tried to help you with that. I hope I met that condition. Looking here at a more easily interpretable graphic, you can see that there was a significant difference in total energy intake per day in the people on the drug versus not on the drug. And this is really seminal information that says, yeah, these do indeed help you eat less. And that's really the pathway for which they elicit not just weight loss, but also recall that the first indication for these drugs was as an anti-hyperglycemic, like an anti-diabetic drug. And if you eat less, you're probably going to be less hyperglycemic. So that's probably one of the key pathways to achieving that anti-diabetic effect. It's also important to note that these drugs stimulate insulin secretions too. But I'm not convinced it's been fleshed out sufficiently enough that that's not the driver of the anti-hyperglycemic effect. Because when we eat more, we produce more insulin, right? That's kind of, there are signals arguing on both sides of that, and much of it's beyond the scope of our presentation. So another thing I just wanted to bring up before I move on to a policy concept is, obesity is in fact a chronic condition, right? So it's been around since I've been interested in this career, and I thought I would solve it, but it's only gotten worse. So I'm a little frustrated with that. This is from one of the step 1 trials, and we're going to be providing all of the references for this presentation in a document that has all links right to these studies. So you'll be able to find this study on your own. It's Wilding et al., part of the step 1 series. Importantly, there's step 1 through 8 already, and there's another whole set of clinical trials called the SUSTAIN trials, and I think there's like SUSTAIN 1 through 7. So these are heavily investigated. Don't hesitate to check out the funding statements on those papers. But aside from that, you can see this chart here, which I'll help you interpret, right? So at 12 months post-therapy, which that vertical dotted line in the middle is when this randomized control trial stopped. It's a little bit after 1 year. But then 1 year after the study stopped, you'll see here that about 2/3 of the GLP-1 induced weight loss was regained. So that says a few things, and it depends on how you interpret it. But one thing it says is that if you want to lose the weight and keep it off using these drugs, you have to really stay on them for prolonged periods of time. And I didn't want to say much more than that, because I think that I wanted to stay centered around the economic implications of that and the policy-based implications, not necessarily, the moral or social implications, or even the physiological ones. We're seeing a lot of evidence that some of the side effects, which are not really, intuitively insidious in of themselves, but they're not that tolerable for prolonged periods of time. I think it's, nausea and diuresis, though, not feeling well in the intestinal tract, are the key side effects, right? And so, it may not be great to be dealing with that for 8 months, 12 months, 14, 26 months. That's a story for another presentation, but I think it's noteworthy that the cost, if you want to continue the condition of weight management over time using these medications, the cost implications will persist. And so this weird euphemistic term that we sometimes use is called weight cycling. Intentional weight loss followed by unintentional weight gain. And some people would say, euphemistically, yo-yo dieting. We try to have a little bit more of a cerebral term, and it's called weight cycling. So I just wanted to pose these two large pieces of epidemiological literature so you can interpret this, right? So this is the study that became known as the fit versus fat study. The title is right there, but this was, over 20 years old now. And it showed clearly that both physical inactivity and BMI, or BMI obesity, explained excess mortality significantly, but also independently. And as a note, obesity made even more powerful the protective effects of physical activity on excess mortality and all causes of disease and all causes of death. That's really important. But after these findings, became made public, people started calling this the fit versus fat study, and that created this a whole line of inquiry, that asked this question, this arcane question, I think, but it shouldn't be arcane. Like, are we better off improving our fitness, or are we better off improving our fatness? And I think, Frank Hugh and his colleagues would probably say you're better off doing both. But what if we're given the choice? What if we said, that fitness stuff, that's really just too hard and there's so much dumb anguish involved with it. I just want to reduce my fatness. Can I, as an individual, and us as a population, appreciate the benefits, in this case, the epidemiological benefits? And that question still is being asked, worldwide. And so that's one of the key studies I wanted to point out. This other one is much more contemporary, the EPIC-2 study. This is the European Prospective Investigation on Cancer Mortality. And there was a large sample size, almost 500,000 people, and they looked at adherence to the Mediterranean diet. So now we're looking at a dietary factor, not a physical activity factor. And adherence to the Mediterranean diet explained a 6% reduced relative risk reduction for cancer mortality compared to people who had poor adherence to the Mediterranean diet. And again, a recurring theme here is that finding was observed independent of changes in BMI or waist to hip ratio, meaning there was something else that mediated this protective effect of diet compared to just being fat in of itself or per se, right? And so those are just two key things I wanted to point out. Why am I so interested in these epidemiology studies? It's because they go on for long term. Those are called oftentimes prospective cohort studies. They follow people prospectively to see if that outcome happens, cancer mortality or excess mortality, right? And at the beginning of the study, none of the participants have the condition, but they follow that and measure these variables, diet and physical activity, and lots of other subclinical measures to see if the outcome happens. The reason why that's important for these lines of inquiry is because a lot of the bad things that we think happen because of obesity take a long time to develop. That's called latency. So some of the short-term clinical trials that investigate the efficacy and the safety of the drugs, that oftentimes they don't endure long enough to answer some of the long-term latency questions that we have about these. And as time passes, more and more information will enlighten us on that important area. But until then, we have some signals from epi studies that really cast really important insight on this, and I just wanted to make you aware of them. So I just wanted to help you interpret where that gap is, right? These drugs, the clinical trials show these drugs work, they help us lose weight. They work, they have very low prevalence of adverse drug events or side effects, right? They do that, right? But do they offset the long-term adverse events, adverse health outcomes associated with obesity? I just posed that question a moment ago, but I wanted to talk to you quickly about issue of confounding, right? And normally randomized control trials are like supposed to control for confounding, but confounding is another way to say confusing. I just wanted to show you this concept called the epidemiologists call the confounding triangle. And look here at the triangle itself. And at the top, you can see mortality risk. That's the outcome. Dying is a bad outcome. I think you know that, right? And we're trying to examine, how much does obesity confer with increased mortality risk? It's directly related to that, right? But then here we look at something that might be a potential confounder, physical inactivity. And we need to ask ourselves the question, is physical activity a confounder for the relationship between obesity and mortality? So we ask ourselves the question, is physical inactivity associated with the outcome, mortality? Yes. Next question, is physical inactivity also associated with obesity? Yes. So therefore, physical inactivity meets the definition of a confounder between the relationship of obesity and mortality risk. This other example here is doing the same thing, but examining the effect of confounding from diet. We know that we've already established that obesity and mortality risk are tightly coupled in a causal pathway. But what about diet? Is Western diet pattern associated with mortality? Yes, we know that. Is Western dietary pattern associated with obesity? Yes, we know that. So both, in this case, both physical inactivity and really Western diet or poor diet, more generally speaking, are known confounders that modify the relationship in one way or another between obesity and mortality risk. And until we get clarity on those associations and can distinguish them from each other, we'll never really understand the true clinical utility or clinical value of any kind of intervention that's in this triangle. So that brings us to this concept. It's a very abstract concept called the obesity paradox. I'll let you read it and then look at the bullets below, which have been suggested as some of the possible explanatory reasons why this obesity paradox exists. And I love me a good conspiracy or a good paradox. It essentially means like what you think might be happening may be something quite different. And again, as a scientist, I don't want to overemphasize this concept because it's really a theoretical framework for which future lines of inquiry, both with regards to clinical study and population-based or epi studies, might ensue. Thinking about this and gaining acceptance to this confounding factor that is really pervasive in the understanding of what's driving disease in these people. So the last thing I want to talk about and talk briefly, if you can imagine that, right, is moral hazard and insurance plan design. Like we refer to this, right, the social harms of obesity in our health insurance paradigm as the obesity externality. And I like how Bacciara and Su defined this a long time ago, like 20 years ago. But it's like if insurance premiums and the cost sharing, so out-of-pocket maximums, are not cognizant of overweightedness, obesity, essentially they ignore it, then the risk for ensuing moral hazard with regards to obesity is very high. Read the epitaph highlighted in yellow and try to think about how that's mechanized in our current system. And think about giving your role in just being here, but also what you do for work, whether you represent providers or insurers or pharmaceutical manufacturers aiming to help people with all the great work that all of you do. How might this system function better to help people? And I'm always very open and seeking of opportunities to help do that. And I think Commissioner Betancourt's effort to give us the opportunity to kind of talk about some of these very contentious and verging on idiosyncratic ideas, that's an example of one of our leaders in the state wanting to make our healthcare system function better for the citizens. And so with that, I'm going to stop there and just leave these summary statements up and ask if anybody has any questions, please answer them now. You can also submit questions in writing to the department through our communications team, and maybe our communications team, AJ and Andrew, who I thank for giving me the opportunity to send this important message along with Commissioner Betancourt. You can send questions right to them through a link that they might post. But thank you so much. I'm blessed to have had this opportunity, and I hope to see you at our fall annual hearing, October 24th, right here at the Brown Building in Concord.
Well, we do have a few questions, Dr. Ezis. Thank you. Thomas Byrne asks a couple of questions. First, he notes a third of the weight loss was maintained. He asks, is that clinically meaningful?
Yeah, so that's a great question, and thank you for it. So clinically relevant, clinically significant, and clinically meaningful, those are different terms with very similar meanings, although not the same. And so one issue that's really impeded answering that question is that there's rather significant heterogeneity in the study populations in these trials. Heterogeneity means great difference. And the heterogeneity resides in several areas. And one of them is the BMI classification. And then the other resides in other comorbidity burdens, other diseases that these folks already have. So if you want to say, well, is that clinically relevant weight loss? I'll come and say, well, it depends upon what disease outcomes associated with obesity we're talking about, because we'd be remiss to think that 20 pounds of weight loss had the same protective effect against heart disease as it did for diabetes, as it did for arthritis, as it did for depression, as it does for peripheral vascular disease. We know that they all have distinct clinical utility curves, improvements in those areas. But when we pull them all together, it kind of obscures the ability to answer that. I will say this, there's much more direct evidence of that heterogeneity effect for cardiovascular outcomes, which is how really, which was a really important pathway, I think, for FDA approval for that indication. Reduce risk for major CV cardiovascular events in people with known cardiovascular disease. But notice how it's secular. It's narrowed down to one population. In a lot of the clinical trials, not all, it was across all populations. So I think the weight is clinically relevant, but really I'm looking forward to see more epidemiology literature that talks about it from an all-cause morbidity and all-cause mortality, because we can find certain subsets of the population. Dr. Sarah Finn, who I'm not sure if she's here today, she's from the Dartmouth Obesity Medicine section. She's going to be speaking at our annual hearing this fall on this very topic, and I will prompt her on that to see if she can enlighten us further. But the epidemiology literature is going to tell people like us, people who regulate populations, not individuals. Clinicians are relegated to looking at the individual and making that one patient better off. Regulators and epidemiologists, like me, we are compelled to look at the entire population. And so there's really, it's somewhat of a strange dichotomy in my life, because I adore and love all individuals, including those here who have not met and those who have met, and people in my family and people not in my family. It's not that the individual is unimportant. It's about where is the return on investment for the whole population? So I thank you for that really compelling question and hope to expand on it as this fall progresses. Please be there to hear more on that.
He has a follow-up as well, Dr. Aziz. He asks, he refers to one of your statements, obese individuals may have more adipose tissue, and he asks, what else would be responsible for obesity?
Other than what?
Apparently, more adipose tissue. I'm not entirely certain.
Well, so known causal factors for obesity are excess total energy intake from a nutritional side, excess total energy intake, excess refined carbohydrate intake, excess saturated fat intake. Those are dietary factors. Insufficient physical activity is a known causal, powerful association with obesity. So those are well-known causal factors and causal pathways. For 30 plus years, that has been well equivocated, reproduced in the epidemiological and clinical literature. So there's that. Now, there are some medications that also are implicated, but the causal associations are much weaker, meaning the pathway in which some medications, like SSRIs, for example, mediate obesity is actually through diet and exercise. So we call those risk modifiers or risk effect modifiers. But there are no more powerfully established risk factors for obesity other than those dietary factors I mentioned and physical inactivity. Now, genetics play a role, but when in multivariate regression models that evaluate this and they control for genetic factors, those associations become non-significant. And a certain very interesting type of study design, secular trend studies, where we're studying different segments of our population and also identical twins who have been separated at birth and live in different cultures, have also really done well to confirm the behavioral associations as causal drivers for obesity. But I'm open to hearing alternative viewpoints on that.
One more question that I see from Honesty Peltier. She asks, are there citations for the statements on the obesity paradox slide?
Yes. Our communications team, I have them listed. I opted to not put in line with text references. Rather, we will send these slides out as a PDF and either a PDF or Word document with all of these references there. Now, the obesity paradox, as I pointed out in the presentation, is a conceptual framework, not, but there's emerging literature in the behavioral economics body of work that talk about that. But it's important to note that without question, a message I want you leaving with is that obesity is agreeably insidious to our population. And if you look at the summary statements, that physical activity and dietary interventions are efficacious but not really effective interventions to help mitigate the epidemic of overweightedness and obesity in our culture. If you want to, please do ask about the difference between efficacy and effectiveness. We know it works, but people aren't doing it. So effectiveness is, what is the real world efficacy like? And efficaciousness is, how does it work in a controlled setting, like a study you're being paid for or a study you're participating in? And though that reality is also known as the bane of my existence, but also it's a key driver to our healthcare system trying to find alternative therapeutic approaches to make this situation better. The question I asked at the end of my presentation was, what part do different actors in this role, including individuals who have, independent of their role in healthcare and health reform or anything like that, what about the individual's role in being as healthy and strong and well as possible? And none of that is off the table for discussion. And that's really an important center of work that the Commissioner Betancourt has given me a lot of latitude to talk about. It's the consumer responsibility. And I wanted to underlie that at the end there. That's a really good question, though, about the obesity paradox.
We've got time for one more question before we turn it over to the Commissioner for closing thoughts. Elizabeth Honigsberg asks, could you please reference a public health intervention or program that successfully impacted adult obesity at the population level, community, state, or otherwise?
Yes, Shape Up Somerville. Shape Up Somerville was a multi-dimensioned, multi-pronged, community-based intervention that involved municipal government, healthcare, and academia, and the school system in the small but well-populated community of Somerville, Massachusetts, and magnificent changes in anthropometry, which is the shape and structure of the human form, anthropometry in the population, and all kinds of subclinical measures like glycemic measures, blood pressure measures, and even cardiorespiratory fitness measures. So Shape Up Somerville started with Dr. Chris Economos, and she showed the roadmap to making our population healthier using this subpopulation. The problem is that scaling that up, there's many barriers to doing that. But that you asked the question, there you have a very, very exquisite, well-designed and cerebral approach to changing behaviors of people in the community. The take-home message for that, because I know that was a forceful response, and I don't mean it to be forceful, I mean it to be clear. The message with that is that our society and our healthcare system mustn't and cannot have a 1 foot in the water approach using behaviors to mitigate obesity. And the result of doing that will essentially result in failure. But there is concrete evidence that's well mapped out. So I thank you for that really, really intelligent question.
Okay, not seeing any other questions, we'll turn it over to Commissioner Betancourt for some final thoughts.
Well, just a phenomenal job, Dr. Azaz. Appreciated very, very much. A lot of information there. As Dr. Azaz mentioned, we will make the slide presentation available, and a recording of this webinar will also be available, and you can access it on our various social media platforms. But today was a pretty comprehensive presentation. I have nothing more I could possibly add other than to say, again, we appreciate you joining us today. We look forward to seeing you on future webinars. Thanks so much.